Welcome to Quickshot session number 2, Basic Science and History. I'm Pam Choi, a pediatric surgeon from Naval Medical Center, San Diego.
Yeah, Stefan Scholz, I'm a pediatric surgeon from Pittsburgh. And the key of the session is really quick shot. So a 2.5-minute presentation, 30 seconds, one question. So you have to think of the questions during the presentation and then immediately jump up. Okay, we'll start with the first presenter.
All right, we'll be starting with Dr. Schermerhorn, to cut or not to cut the history of non-operative management of the appendix in pediatric surgery procedures.
All right, good evening. My name is Sophia Schermerhorn, and I'm a surgical resident at Naval Medical Center, San Diego. I'll be speaking today about the history of the non-operative management of the appendix in pediatric surgery. I want to thank APSA for the opportunity to speak at the podium and share this information with you today. I have no disclosures. As you may already know, the appendix was first described anatomically by Da Vinci in the 16th century, but appendicitis was not described as a pathological entity until 2 centuries later by Dr. Heister. This was then followed by the well-known first appendectomy by Dr. Amian, who performed an appendectomy for perforated appendicitis, incidentally noted in an inguinal hernia. For the next century, appendectomies were surgically treated through a right lower quadrant incision, popularized by Dr. McBurney, until the 20th century, then laparoscopic appendectomy was first invented by a gynecologist, Dr. Kurt Sem. While surgical treatment has been the prevailing approach since the discovery of appendicitis, there's always been dissenters. In the early 20th centuries, Dr. Ochsner and Sharon advocated for narcotics and bowel rest as an alternative to surgery and created the first formal regimen for an interval appendectomy. Unfortunately, in the pre-antibiotics era, the mortality of their approach was high. This debate resurfaced again in the past decade with multiple randomized controlled trials advocating for the safety of antibiotic-only treatment. Outside of appendicitis, there has been debate about the surgical removal of the appendix in the context of other surgical procedures in pediatric surgery. Traditionally, the LADS procedure performed for malrotation includes an appendectomy as the final step to mitigate the diagnostic ambiguity of the appendix's new location in the left hemiabdomen. Intriguingly, Dr. Ladd did not include an appendectomy in his original 1936 description of this procedure, and there is now renewed interest among pediatric surgeons to exclude appendectomy in this procedure. Similarly, in the 1950s, incidental appendectomies were advocated during open reductions of intussusception to avoid diagnostic dilemmas in the case of recurrence. This practice was also performed in the case of Meckel's diverticulum and gynecological surgery such as ovarian torsion. These practices have come into question with improved diagnostic imaging and improved knowledge of the appendix's function. In conclusion, while surgical removal of the appendix has been the mainstay of treatment for centuries, there have always been dissenters, and in the 21st century, there is now evidence to support these questions if surgical removal of the appendix is indicated or if alternatives should be considered. The question is, will this trend towards non-operative management continue, or will the pendulum swing once again? Thank you, and I'd like to thank Dr. Ignacio and the rest of the Rady Pediatric Surgical team for their support in the project. Now I'll take questions.
Was Dr. Amia trying to perform a appendectomy, or is he trying to fix an inguinal hernia repair when he incidentally just found the perforated appy?
So I believe it was a case of an intercutaneous fistula that was in the inguinal hernia, so he did not know that the appendix was located at the time, but then when he discovered it, ligated and performed the first appendectomy.
I was wondering, do you know, historical-wise, what drove now the reappearance of the non-operative treatment? Why? Why is this coming up now again? Because we're all very slick. We're doing appendectomies.
In the current last decade, sir, I think a lot of this is being driven towards questions if, in general, I think there's been a lot of questions if we should take a non-operative approach to different scenarios. So I think that's in general the trend that we're moving towards in medicine, at least asking the question if we can be less invasive or less operative.
Okay, so thank you very much.
Thank you.
So moving on to the next presenter, and this is Nicole Chimbach from Patching the Hole in the History of Congenital Diaphragmatic Hernia.
Good afternoon, everyone, and thank you for the opportunity to present our work. We have no disclosures. What we understand about current CDH management revolves around advanced therapies. What I'm going to talk about today is how CDH was diagnosed before the advent of these therapies. In 1701, Sir Charles Holt of London first described CDH in a post-mortem patient as a knot of small eels that was found within the thoracic cavity. Interestingly, he also noted that there was severe pulmonary hypoplasia present on exam. In the late 1700s, Morgagni, an Italian anatomist from the University of Padua, also described the anterior diaphragmatic hernia. And later, Victor Bastelek, a Czech physician, described the posterior lateral defect, which still bears his name. Interestingly, he is actually more known for his contributions to neuroanatomy during this time period than CDH. During this time period, more diaphragmatic hernias were unfortunately diagnosed during autopsy. René Laennec, a French physician, invented the stethoscope, which is a wooden instrument seen in this photo, and he actually recommended that this be used for the diagnosis of CDH. He was also the first physician to recommend surgical intervention for CDH, because up until this point, no successful surgical CDH repair had been completed. It wouldn't be until 1889 in New York when Dr. O'Dwyer would use a patch to actually complete the first abdominal approach CDH repair. And then in 1929, Bettman and Hess completed the first infant CDH repair. Bettman was a surgeon, but Hess was actually a neonatologist who was also credited with the invention of the neonatal incubator during this time period. In the 1940s, Dr. Gross completed the first neonatal CDH repair out of Harvard. And what he actually noted was that this was the first advanced management that we now know today to be the basis of our management of CDH. And he had three main takeaways. The first was that a good anesthesiologist can make your operative repair a lot easier. The second was that a delayed closure is possible. And the third is that the position of the mediastinum within the chest actually matters for hypoxia and a patient's outcomes. There have been a number of other significant medical advances over the past decades that have all contributed to improved survival rates. However, we all know of the patients who are still unable to be weaned from ECMO flows, who have maximized their pulmonary hypertension therapies, and it often leads us to wonder, where do we go next? And sometimes during these times, it's important to remember that the best sailors are those who have studied the charts and records of those who have sailed before. Thank you.
Thank you, Dr. Simback. In the interest of time, we're just going to move ahead.
Sure, thank you.
All right, next we have Dr. Alyssa Joachim, short bowel, long history, the history of bowel lengthening surgery.
Oh, thank you. All right, thank you for that introduction and thank you for having me. I have no disclosures. So short bowel syndrome is a malabsorptive state that is diagnosed on a clinical basis rather than solely based on the amount of bowel that one has. And the most common cause for it is extensive bowel surgery. It's currently treated in a multidisciplinary fashion with options such as TPN, surgery, and medication management. Today I'll be talking about the surgical options, specifically bowel elongating surgery. The first surgery was performed in 1980, described by Dr. Bianchi. It's the longitudinal intestinal lengthening and tailoring surgery. It takes advantage of the physiologic changes that happen in short bowel syndrome, specifically the dilatation of the bowel. So the bowel is divided, maintaining the mesentery on both sides of the division, and then anastomosed in an end-to-end fashion. The most complicated part of this surgery is dividing the bowel such that mesenteric supply is to both sides. So in 1993, Dr. Kimura at the University of Iowa developed a procedure that allowed for neovascularization of the antimesenteric side of the bowel using primarily either the liver or abdominal wall as a host organ for vascularization, and then performed the procedure similar to the lilt. Following this, Kim et al. In 2003 described the serial transverse enteroplasty procedure. This is the most commonly used procedure today and was primarily developed as a way to have a less complicated surgery. So it avoids the complicated hand-sewn anastomosis. It's transverse staple lines to elongate the bowel. All of the three prior surgeries depend on significant dilatation of the bowel. So in 2011, Cerny et al. Described a method that does not require as significant of dilatation called the spiral intestinal lengthening and tailoring surgery. This is a longitudinal spiral cut of the bowel, and the bowel is then elongated in that fashion. And then finally, recently, Dr. Dunn has been doing significant work on distraction enterogenesis, which is a method that would allow for an endoscopic lengthening of bowel using self-expanding springs that induce longitudinal cellular proliferation, which has been effective in both pig and mice models. So this timeline kind of represents the history of bowel lengthening surgery and nicely demonstrates how understanding both the advantages and disadvantages of the procedures performed in the past can help us to develop the procedures of the future. Thank you, and I'll take any questions.
I would like to note that Dr. Kim is also in the audience, who invented the step procedure. Just we have some historical giants in the room. And this is probably the mainstay of today's bowel lengthening procedures being done in centers, since it can be repeated and is a fairly straightforward approach in difference to other procedures, obviously. I don't have any other questions. Any questions from the audience? Any anecdotes? Any stories? Brief? Okay. Then we'll just move on. Thank you very much.
And I'll be presenting Dr. Hyman's as well.
Oh, okay. The next one is Tracing the Timeline, Historical Perspective of the Treatment of Intussusception by Simone Hyman, but we have a different presenter who is also Alyssa Joachim.
All right. Thank you for having me. I'll be presenting on behalf of Simone Hyman, who is unable to make it today, Tracing the Timeline, a Historical Perspective of the Treatment of Intussusception. No disclosures for this slide. So there have been multiple studies on the best treatment for pediatric intussusception, and today our standard of care is to do multiple trials of pneumatic reduction, assuming the patient is hemodynamically stable. So we're going to review how did we arrive at that current state of practice. So the first description of intussusception was actually thought to be by Hippocrates around 500 BC, although it's unclear if he was actually describing intussusception versus ileus. However, he did describe that it could be treated with inflating the bowels with bellows to address the problem, which ironically is similar to how we treat intussusception today. Then next, Barbette presented the first case of what had not yet been labeled intussusception in 1674. He described intestinal invagination at that time. Following this, in 1789, the term intussusception was formally coined by Dr. Hunter, where he wrote about 3 patients with this telescoping bowel physiology. Throughout the 19th century, primarily operations were done to treat intussusception, and the first done on an adult was by John Wilson in 1831, and then the first manual reduction in a child was done in 1871 by Jonathan Hutchinson. During this time, there were also trials of non-operative management, and the first case of successful air enema reduction was in a child in 1836. Following this, in the late 1800s and early 1900s, Harold Hirschsprung cataloged his experience using hydrostatic enemas to treat intussusception, and he documented a 70% survival rate. Despite the increasing evidence for the efficacy of non-operative management, many surgeons still did surgery as a primary method of treatment. However, that changed somewhat in 1948 following a publication by Dr. Rotbich, which boasted a success rate of approximately 75% with barium enema protocols. In 1977, the description of the ultrasound target sign was first described by Dr. Burke and is now used as our primary diagnosis. In 1986, GU reported a 95% success rate using air pressure enemas in a case series of 6,000 patients. And then finally, in 1994, a study in New Zealand described that multiple pneumatic reductions could be attempted in patients that had not succeeded on the first, which leads us to our final format of how we treat intussusception today. Thank you.
Okay. Thank you very much. There's a question, a comment?
You pronounced the name Ravitch incorrectly. It was Mark Ravitch. And it's actually the same person who pioneered the pectus excavatum repair. He was when he was a surgery resident, he did the research and presented the data.
Mark?
Thank you.
Yeah, there was a mistake on the timeline. I think it was 1908. This was in the 40s when Mark Ravitch in Pittsburgh, actually, he even published a book on it, popularized more or less the air enema, for. Thank you.
Thank you.
Thank you, Dr. Joachim. All right, next we'll have Dr. Joseph Lee presenting Unearthing Historical Milestones, Pioneers and Contributions to Necrotizing Enterocolitis.
All right, good evening. My name is Joe from San Diego, and thank you to the committee for this opportunity to discuss early landmark contributions to the understanding and management of NEC. I have no disclosures. In addition to a literature review, I interviewed Dr. Robert Talukian, a past APSA president, about his experience with NEC in the 60s. In 1823, Charles Spiller provided the first documented case report of NEC, describing it as gangrenous enterocolitis in a neonate. 60 years later, Arnold Paltov described intestinal necrosis and perforation in newborns. In 1943, Aggerty and colleagues, how do I go back? Aggerty, it's not progressive. Yeah, it stopped working. The clicker's not working either. Oh, there we go. Thank you for that. Aggerty and colleagues published the first survivor after resection for NEC. With the increased survival of premature infants in the 1960s, Dr. Walter Burton published radiographic and postmortem findings of NEC. And in 1967, he, Dr. Talukian, and Dr. Santulli described the management and outcomes of NEC in 25 cases at the baby's hospital, concluding that pneumatosis alone should not be an indication for operation, recommending laparotomy only after the development of pneumoperitoneum. In 1975, Dr. Santulli hypothesized that the development of NEC requires injury to the intestinal mucosa, the presence of bacteria, availability of metabolic substrate, and this remains the core of our understanding of NEC today. In 1975, Dr. Martin Bell and colleagues developed the clinical staging method distinguishing medical and surgical NEC. I had the privilege of interviewing Dr. Talukian, who is now the last surviving member of Dr. Santulli's team. Based on the appearance of the bowel and predisposition of premature infants for circulatory insufficiency, they identified intestinal ischemia as the etiology of NEC. Dr. Talukian emphasized the importance of teamwork among specialists, which we now take for granted, with pediatric radiologists who assisted in diagnosing pneumatosis and perforation, and dedicated NICU staff and anesthesiologists who facilitated bedside intubation. The past 5 decades have brought a nuanced understanding of NEC pathophysiology, including the roles of proteobacteria, TLR4, and other inflammatory mediators. Breast milk and probiotics have been identified as protective, along with agents such as lactoferrin. Operative management have been refined, exploring peritoneal drainage, stoma construction, and primary anastomosis. This brings us to the fascinating age of today, where experimental therapies for NEC, including EGF, stem cells, breast milk-derived vesicles, and TLR inhibitors continue to be developed, along with a series of novel therapies presented at this meeting. Again, thank you for the opportunity and thank you for your time. I'd like to especially acknowledge my mentors, Dr. Ignacio and Dr. Gollin, and happy NEC Awareness Day.
It's obviously, we will move on, but it's obviously tough in 2.5-minute presentation to get over the history of one of those and ask him questions. But we'll move on to the next one, surgical management of gastroschisis then and now, from Cody Dalton, presented.
All right, thank you for the opportunity to present our work. I have no disclosures. So gastroschisis, as one of the most common fetal abdominal wall abnormalities, has been of clinical interest to me since I was a medical student. Although historically having significant morbidity and mortality, advancements in medical and surgical care have improved outcomes for gastroschisis in the United States. However, globally, there remains a considerable number of complications and high mortality in low-income countries. Thus, it is critical to review where management of gastroschisis began and where it is now. In his publication, In Medical Essays and Observations, James Calder first described gastroschisis as an infant having a large share of its intestines lying without the teguments of the abdomen, with the navel intact containing a perforation. Soon after, William Hay described an infant death after full primary reduction of all bowel contents into the abdomen for an infant with a similar defect. A whole century later, William Fear depicts the first successful reduction of bowel by pulling the abdominal skin into a conical shape overlying the replaced bowel and tying it off with a string. And later, Edward Watkins performed a successful primary reduction by first extending the abdominal defect. This highlighted one of two major challenges with the early management of gastroschisis. The first one being obtaining adequate abdominal wall domain. From the 1940s to the 1960s, multiple techniques were described for enhancing abdominal wall domain, such as creating skin flaps to cover the defect. In 1967, Schuster et al. Described the use of opaque plastic coverings used to contain and protect the bowel while it was serially reduced. This, of course, presented the other main challenge, which was the inability to examine the bowel for viability while serial reductions ensued. This brings us to 1975, when Schermetta et al. Introduced the transparent silo with the compressible intra-abdominal ring to keep the silo in place. This paved the way for the staged closure and the staged sutureless closure technique, which of course is widely used today. This technique has evidence for reducing general anesthesia, mechanical ventilation, surgical site infections, and time to enteral feeding. And with that, I thank you for allowing me to present my work, and I will now take any questions or comments.
The sutureless closer was used by Adrian Bianchi in the 90s in Manchester, separately really from the Americans. So there were, and also by other surgeons actually at the time who didn't publish it, but I don't have any other questions really. Anybody else? There's a question in the room. You have 5 seconds. Running to the mic.
Out of curiosity, I'm just curious to know what were the biological insights that led to sutureless closure even being considered as a way to try to replace this? Do either of you know anything about how that came to be? Because sometimes I think, yeah, we can think about cutting and sewing, but how do we come up with that?
I actually didn't delve into the details really of that part of the sutureless closure and the development of it, but I think that's really interesting to look at, especially considering it is a pretty big transition from closing with suture. So, yes.
One thing I would offer on this, Gene McGarren, UVA. One thing I would offer there is that as we talk about the history, we hear about trying to get a domain to get the bowel back in. And I think thinking in terms of more of the bowel swelling going down, and what we're really doing is protecting the bowel while the swelling goes down, and the body kind of allows it to be protected. So I think that's where the sutureless closure idea really kind of aligns with what we accomplish.
Great. Thank you.
All right, Dr. Gershner will be presenting utilization of VA and VV ECMO in pediatric surgery through history.
Hello, and thank you for the chance to present our work. We have no disclosures. ECMO was first conceptualized in the 1970s by Dr. Robert Bartlett. It was then first performed successfully in adult in 1972, and then in a neonate in 1975 with the well-known baby Esperanza, who's pictured here successfully with Dr. Robert Bartlett. It's later garnered support for the treatment of severe pulmonary disease through a series of randomized controlled trials in the late 1980s. In pediatrics, initially VA ECMO was mostly used due to size limitations of the cannula being too large for pediatric patients. While VA ECMO was effective, it carried the risk of neurologic complications and required sacrificing the carotid artery after the ECMO run. Single-site dual-lumen cannulas were developed and increased in usage during the late 1980s. The initial was the Origin right atrial cannula, which recently was removed from the market. In 2009, the Avalon Elite VV cannula became available, and later in 2018, the Crescent bicaval dual-lumen cannula was released. These single-site techniques led to the increase in VV ECMO usage. While VV ECMO carries a decreased risk of neurologic complications, it does come with the reported risk of cardiac injury and possible perforation. In summary, ECMO has deep roots in pediatric surgery thanks to Dr. Robert Bartlett. It remains one of the last resorts for critically ill neonates with cardiopulmonary compromise. Developments in cannula size and technologies allow for different techniques on different ages of patients, and VA and VV ECMO have their own indications and subsequent inherent risks. Thank you for your time, and at this point, I'll take any questions.
Any comments, questions on ECMO, potentially from a historical perspective? Okay, well, we'll move on to the last talk from this historical part of this Quickshot session. And that's From Womb to World, Tracing the Evolution of Fetal Surgery. This is presented by Sean Izadi.
Thank you for the opportunity to present. We have no disclosures. I hope everyone's buckled up. We'll cover all of fetal surgery in 2 minutes. We'll start in 1881 when the first amniocentesis was performed by Wilhelm Lambel of Germany for polyhydramnios. And it wouldn't be for another 100 years until Michael Harrison, or as some would call the father of fetal surgery, would perform the first open fetal surgery for urinary tract obstruction at UCSF. Around that time, Michael Harrison, amongst the international community, saw the rising interest of fetal surgery and formed the first group, being the International Fetal Medicine and Surgery Society, laying the groundwork for many fetal surgery principles that we use today. Now, we can't talk about fetal surgery without talking about the innovation that's come alongside it, primarily fetoscopy, with the first being performed in 1974 by Hobbins and Mahoney for diagnostic purposes. But this spearheaded the movement away from open fetal procedures towards a minimally invasive approach. We also look specifically at the ultrasound, which is a popular tool for fetal surgeons. And the first prenatal diagnosis of CDH with the ultrasound was done in 1977 by Garrett and Kossoff. Now, as you can see, ultrasound at that time to where we are today has come a long way due to better processing power and higher resolution. Now, a big challenge for fetal surgery was proving that the operations and the procedures were not only okay and safe for mom, but beneficial for the fetus. The Eurofetus trial in 1999 showed the benefit of laser coagulation for twin-twin transfusion syndrome, and then the popular MOMS trial showed the benefit of open fetal repair for myelomeningocele in a randomized controlled fashion. The total trial was an observational study, but showed the benefit of FETO in severe CDH. In conclusion, the role of fetal intervention remains a rich platform for innovation and the meticulous study of outcomes, and fetal surgery continues to be ignited by advances in technology, neonatology, stem cell and gene therapy, and beyond. And some of the big players in those spaces right now, to name a few, are Diana Farmer for her work in spina bifida, Alan Flake and his work in the artificial placenta, and Dario Fauza and his work in the transamniotic stem cell therapy. Thank you, and I'm happy to take any questions.
I have a question.
Heiss from Atlanta. Weren't some of these innovators attacked for experimenting on babies when they introduced fetal surgery and extracorporeal circulation? If I remember right, I think a number of them underwent a lot of personal attacks when these innovations occurred.
Yeah, back in the 70s and 80s when this was happening, there were a lot of attacks. I think that was one of the main reasons why Michael Harrison wanted to form the international community, just to put guardrails up, given the popularized interest of fetal surgery at that time, and preserving the integrity of the specialty moving forward, and understanding that there needed to be these randomized controls trials and studies to prove the benefit to the community scientifically. Thank you.
Thank you. We'll be shifting to our basic science abstracts with chemical pancreatectomy increases beta cell volume and eyelid vasculature by Dr. Krieger.
Good evening, and thank you for the opportunity to present. It's not moving. Press it. We have no disclosures. So in order to understand why we did this research and why we think it's important, it's first necessary to have a little bit of background information regarding the chemical pancreatectomy. So this is a procedure which was kind of serendipitously discovered by our lab several years ago, which involves an intrapancreatic duct infusion of 1% to 2% acetic acid in mice and non-human primates, and leads to near complete ablation of the exocrine pancreas while perfectly preserving the endocrine islets. And that can be seen grossly in the pictures on the top on the left, and histologically on the bottom left pictures. Now, interestingly, our lab also found that this procedure led to improvements in glucose tolerance in these mice, as well as increases in insulin secretion. So we performed the following series of experiments in order to determine what the mechanisms were underlying these improvements in glucose homeostasis. And we feel that this is particularly important because we one day plan to use this procedure to potentially treat a variety of pancreatic diseases, such as cystic fibrosis-related diabetes or chronic pancreatitis with pancreatogenic diabetes. What we found through these experiments were that chemical pancreatectomy leads to an increase in the beta cell volume that's present throughout the pancreas. Furthermore, in the pictures on the right, you can see three-dimensional whole mount imaging of islets after either chemical pancreatectomy or normal saline infusion, and quantification that shows increases in islet volume, islet perfusion, and islet vasculature. And collectively, we believe that these changes that are induced by the chemical pancreatectomy underlie these improvements in glucose homeostasis that we see and are part of what makes it such an appealing therapy for these pancreatic diseases. Thank you, and I'm happy to take any questions.
Any questions? No, just okay. One question I have, so you're killing the pancreas with alcohol, but why do these islet cells survive?
We think it's a combination of factors. We have some in vitro data that suggests that the whole islets, the islet capsule, provides a protective effect. There also might be some element of the proximity of the duct and where we're infusing the acetic acid that leads to more damage to the exocrine pancreas as opposed to the endocrine being more protected. But all in all, we're not 100% sure regarding the total mechanisms by which the exocrine pancreas is ablated and the endocrine is preserved.
But because of the chronic pancreatitis, the islet cells suffer and can't perform and go down over time. So it's a mistake of nature to place islet cells into the pancreas in the first place.
It's an excellent point.
All right, thank you.
Thank you.
Next up, we have evaluation of irrigation solutions on intra-abdominal abscess and adhesion formation in a perforated appendicitis murine model by Dr. Derek Crennock.
All right, good afternoon. My name is Derek Crennock, the current Pediatric Surgery Research Fellow at Arkansas Children's Hospital. And today I have the opportunity to present our findings evaluating irrigation solutions on intra-abdominal abscess formation and adhesion formation in a perforated appendicitis murine model. This research was, is it the right click or?
Green button or the mouse?
What?
Is this one here?
Okay. This research was funded by an intramural grant at Arkansas Children's Hospital. So we elected to study the topic of acute appendicitis because it is one of the most common surgical diseases in children. Intra-abdominal irrigation has been proposed as a method to decrease post-op abscess formation after appendectomy for perforated appendicitis. We hope that our findings will help to direct future studies that investigate irrigation use in this surgical disease. Povidone iodine has been proposed as an irrigant, but we observed significant intra-abdominal adhesions following use in our preliminary studies, so we included tacrolimus, an immunosuppressant, as a potential irrigant as well. The purpose of our study was then to determine the effect of intra-abdominal irrigation on postoperative abscess and adhesion formation. We simulated a perforated appendicitis model by having mice undergo an initial survival surgery during which a cecal ligation and puncture was performed. 72 hours later, the mice then underwent a second survival surgery where a distal cecectomy was performed as well as intraperitoneal irrigation. In addition to a control group of no irrigation, irrigation solutions included normal saline, 2% povidone iodine, and 2% tacrolimus. Mice subsequently underwent necropsy at 2 weeks and 2 months after the second survival surgery, where intra-abdominal abscesses and adhesions were counted. In the 2-week cohort, prevalence of abscesses was 74%, and abscess rate was dependent on irrigation groups. Pairwise comparisons demonstrated that povidone iodine significantly decreased the abscess count when compared to the other groups. And the adhesion grade was also dependent on irrigation solution, with tacrolimus decreasing adhesion grade as well. Within the 2-month cohort, intra-abdominal abscess rate was 42%, and similar responses to irrigation solutions were observed with povidone iodine irrigation showing decreased abscess numbers, while tacrolimus irrigation had decreased adhesions. In conclusion, povidone iodine irrigation resulted in decreased intra-abdominal abscess formation at the increased cost of adhesion formation, while using an immunosuppressant decreased the adhesion burden but did not have an effect on abscess formation. Thank you.
Okay, go ahead, please.
For the control where you have no irrigation, that you should, does that also imply that you suctioned all the fluids that's there? Because another way to treat this is not to suck out everything and then leave it at that.
Yes, yeah, we removed any sort of fluid that was in the mouse at that time.
Do we have time?
Yes.
So Rome Ignacio, San Diego. Very interesting study because, as you well know, there is a multi-center study that now is looking at that. So can you comment about that? Because there is some concerns, obviously, in your animal model. And now here's this multi-center study trying to look at the role of povit iodine for abscesses after perforated appendicitis.
Yes, I believe that that is a multi-center study that we are going to be a part of. And, you know, with our adhesion formation, that would obviously look at early postoperative small bowel obstruction. And, you know, we could see that at the 2-month time period, the adhesion grade did decrease, but was still present in the betadine group. And so, you know, obviously, we don't know for sure how long in a human the adhesions would last. I would say also, you know, those surgeons at our institution that use betadine irrigation, they actually use a 1% solution, and we use 2% for this study.
Well, why did you use 2%?
That is what we had calculated, you know, in terms of what we were going to start with. And then we actually adjusted it based on finding out that 10% and 5% betadine solutions did not work well with the mice. It ended up killing them all. But then we also found out after the fact that it was the surgeons were using only 1%. So we just had started the study using a higher concentration.
Thank you.
Thank you.
So, yeah. So the next presentation is from Jessica Müller. The enteric glial cells that persist in Hirschsprung's disease are minimally neurogenic.
Hi, good afternoon. My name is Jessica Mueller. I'm a surgical resident at Mass General Hospital. And this evening, I'd like to talk to you about a population of enteric glial cells that persist in Hirschsprung disease. Okay, we have nothing to disclose. In this study, we identified a population of enteric glial cells that persist in the intramuscular space in Hirschsprung disease. And this is important because glial cells are the main source of neurogenesis postnatally. And so these cells, this population of cells, therefore represents a potential reservoir of cells that could theoretically become neurons, which could be important for repopulating the aganglionic zone. So we performed single-cell RNA sequencing of the distal aganglionic and proximal ganglionic colon of Hirschsprung mice, as well as the corresponding segments from wild-type mice. And we found 3 populations of glial cells that corresponded to Schwann cells, intraganglionic glia, and extraganglionic glia. And when you stratify the samples based on location and disease, in the knockout distal colon, so the diseased segment of colon, we see the absence of both neurons and intraganglionic glia, which makes sense to us. But we see the persistence of a population of Schwann cells and the persistence of a population of extraganglionic glial cells. And so we validated this using immunohistochemistry. And so on the bottom left, we stained for PLP1, which is a glial marker, as well as SOX10, which is a glial marker. And you can see in the top row, this is an aganglionic mouse, a Hirschsprung mouse. You can see that there are glial cells that are existing outside of these nerve fibers that correspond to these extraganglionic glia. The bottom row is a ganglionic segment, and you can see that there are glia within the myenteric ganglia, as well as glia that live outside of the myenteric ganglia. And looking at our single-cell data, we were able to identify a unique transcriptional markers for these populations and stain for them independently. We then wanted to investigate if this population of cells existed in human tissue. And so on the bottom left, you can see that we stained both ganglionic proximal colon in a Hirschsprung sample, as well as the aganglionic segment. And we stained for S100B, which is also a glial marker, and found that there is this population of glial cells that are residing within predominantly the circular muscle. Lastly, we developed a serial filtration method to culture these cells separately, and then use flow cytometry to sort them for GFP, which was a marker for PLP1 or a glial marker. So we're starting with a pure glial population, plated them on fibronectin, and then ultimately stained for HU, which is a pan-neuronal marker. and found that the extraganglionic glial population at baseline is less neurogenic than the intraganglionic glia. But when you culture them in the presence of GDNF, which is a neurotrophic factor, their neurogenic potential increases. Thank you. Any questions?
Thank you. To stay on time, we're going to move on. All right, next we have automated quantification of liver fibrosis at diagnosis in biliary atresia patients using a collagen matrix ultrastructure analysis by Dr. Nora Liang.
So I hit the mouse to advance. Yes? Okay.
Left mouse or green button?
Left mouse or green. Okay. Thank you, everyone, for the privilege of the podium. I have no disclosures today. Biliary atresia is a fibro-obliterative disease characterized by progressive intrahepatic fibrosis and is the most common indication for pediatric liver transplant. This progressive fibrosis is a poorly understood but key aspect of this disease, and understanding its features and pathogenesis is important for improving native liver survival. Currently, there are limited tools with which to describe liver fibrosis and biliary atresia. Today, I present a method for objective and automated quantification of liver fibrosis at the time of BA diagnosis with potential for prognostic value. In our study, we proposed the application of a Mason's trichrome-based image processing algorithm to quantitatively examine the ECM ultrastructure of liver biopsies obtained from BA patients at the time of their diagnosis. We identified a sample of 8 patients who had undergone Kasai between 2015 and 2022 at our center and had liver biopsies banked in our pathology archives. Retrospective chart reviews were performed to stratify these patients into 2 cohorts, those who had undergone transplantation at the time of our study and those who had not, and then transplant-free survival was calculated for all of these patients. Stained biopsies were then subjected to an ultrastructure quantification algorithm that characterizes 147 different ECM fiber features, such as fiber length, packing, and width. And pseudotime analysis was subsequently applied to illustrate the trajectory of liver fibrosis, which is seen here on the right, with medium pseudotime summarizing overall fibrosis for each patient. On the right are some representative histology specimens corresponding to mean pseudotime along the trajectory that we calculated. The collagen fiber feature matrix was then reduced by UMAP to visualize differences in overall matrix architecture between the 2 cohorts. Liver specimens from the transplanted cohort were associated with high mean pseudotime, characterized by increased heterogeneity in collagen fiber length and diameter compared to the non-transplanted cohort. And then this is illustrated in the density plots shown here with increased rightwards trajectory associated with increased pseudotime. And finally, looking at transplant-free survival, Pearson correlation suggested an inverse trend between mean pseudotime and transplant-free survival. So in conclusion, we present the first application of an automated ECM ultrastructure analysis to quantify liver fibrosis at diagnosis in patients with BA. Our preliminary correlation suggests that higher mean pseudotime may be associated with decreased transplant-free survival, and pending further validation, fibrosis summarization of BA patients via mean pseudotime could provide useful prognostic data for patients and their families. Thank you. I'm happy to take any questions.
No questions? I can't think of a question either. I mean, it seems to be a pretty useful tool potentially. You know, and I would encourage you to obviously take liver samples and use this method further to validate that. You know.
Yeah, what's nice is that oftentimes the pathology lab will already stain for Mason's trichrome, so you can just pull that from the archives and you can scan it.
Interesting, maybe also at one point, would you not offer a Kasai procedure and then move on to a transplant essentially?
Yeah, I think that mean pseudotime could potentially give us some idea of that, but we'll need more samples.
Okay.
Thank you
very much. Okay, our last but not least talk at the session today is the development of a synthetic intestinal graft with mechanically driven peristalsis for the treatment of short bowel syndrome by Cody Trageser.
Excellent. All right. I'm Cody. I'm a surgery resident at VCU in Richmond, Virginia, and a research fellow in Dr. Hackham's lab at Johns Hopkins in Baltimore. Let's see about this mouse. Excellent. No disclosures. So we're primarily a neck lab, but we're keenly interested in short bowel syndrome. Because of this pie chart, neck accounts for about a third of all cases of infantile SBS, so it's the leading cause. And unfortunately, a lot of the medical therapies are sort of just supportive, and a lot of the curative surgical therapies either have really high morbidity or limited windows of candidacy. And so, in our minds, kind of the holy grail for these patients would be an intestinal graft that is minimally, immunogenic and has all the same properties of native bowel. And for the last 10, 15 years, our lab and others have been making progress on several of those characteristics. So, to get the massive surface area and the microvillus structure of native bowel, we developed a bioscaffolding that could be seeded with organoids to produce a functional epithelium. And then we took the combination of those two things and implanted them for about a month in mouse omentum and showed that you could get spontaneous neovascularization. So the green staining there is von Willebrand factor. But the component of this, the kind of the most elusive piece of this puzzle has been how to establish motility in these grafts, and that's what my part on this project has been and what I'll be focusing on today. So I'll start with what our approach is. This is a little out of order, so we'll just see what happens when I click. This is a mechanically driven model of peristalsis through externally applied electromagnetic waves. This would be the diagram if this weren't in the way. That's unfortunate. We start with a piece of tubularized porcine submucosa. It's a substance called core matrix that we just run together with an 8-0 nylon and form a tube, and that's our intestinal graft. And then, yeah, that's a picture of it there. To that, we apply a scaffolding with magnets that are arranged in an alternating polarity, such that when they are passed through a magnetic field, they rock and they deform the graft and they form peristaltic waves. And so I'll just show you the videos that are apparently eager to be shown of it in action. Here's a rat under anesthesia with the graft being deployed. This is under a skin closure, and this has been previously loaded with India ink, so you can see propulsion of that from the distal exteriorized end. So yeah, we are working every day to make this more sleek and less bulky and less ghastly appearing, but we're excited to see how this approach to peristalsis evolves into another treatment for patients with SBS. Thank you.
Any questions on this method? There's one over there.
Yes, sir. Absolutely. Yeah. Well, trying to get this to fit in a rat's abdomen has been hard enough. And at this point, the engineering of this is the main hurdle. We can only make these magnetic pieces so small, or they can't actually generate a force large enough to deform the intestine. An alternate way to capitalize on how hard it is to get more than just a straight short segment in the abdomen is that you can run this both antegrade and retrograde, thus kind of multiplying your effective surface area by as many times as you need. But that is an engineering problem that we are working to solve. Thank you.
Like one question regarding the concept. I didn't totally understand it because that scaffold has the magnets.
Yes, sir.
But then you're implanting the magnets into the patient or the mouse.
Yeah,
so the magnets are going to be on the inside.
So the magnets are sort of worn as a jacket around the intestinal graft, which would in the end have a functional epithelium on it. In the video that I showed, the two ends of that intestinal graft were not in continuity with the bowel. It was just implanted and exteriorized for the sake of the model. But yes, it's designed to be an end-to-end anastomosis on each end. Yeah.
Okay. Thank you very much. I think we can close the session with this. Thank you. Thanks for coming so late.